Hi, this is Farhan Mirza. I will be discussing our chapter Growing Skull Fractures by myself and Dr. Thomas Pittman from the Department of Neurosurgery at the University of Kentucky. The objectives of this chapter are to understand the historical significance of growing skull fractures, understand the occurrence and pathogenesis of growing skull fractures, identify patients with high-risk findings and strategize treatment accordingly, and discuss observation and treatment methodologies. Growing skull fractures are rare and occur almost exclusively during the first few years of life. Several terms have been used to describe these fractures, including traumatic ventricular cyst, craniocerebral erosion, cranial malacia, leptomeningeal cyst, amongst others. However named, growing skull fractures are easy to recognize. They appear mostly as soft subgaleal collections, overlying an enlarging bony defect at the site of a previous diastatic fracture. Treatment is operative. Sufficient bone must be removed to allow the dural edge to be identified and dural closure accomplished. This can be, on occasion, a more formidable task than might be expected. John Howship, a general surgeon in England, was the first to report a patient with a growing skull fracture. In 1816, he described a 9-month-old child in whom, after an injury, an enlarging defect of the parietal bone developed. According to his notes, the opening in the cranium remained undiminished. Upon laying the hand on the part, the pulsations of the brain were felt strong and distinct. First account of the pathology of this condition was by the famous pathologist Karl von Rokitansky in 1856. Sporadic accounts of similar cases were published over the ensuing 50 years. Sir Rickman John Godley wrote in 1885, "The fracture referred to can apparently only occur in young children. It is a simple fracture and is accompanied at the time of the accident by what appears to be an ordinary hematoma beneath the periosteum. But this hematoma is noticed either immediately or after the lapse of a certain time to pulsate. Eventually, it is found that there is an aperture of considerable size in the skull, and if the child dies, not only is the dura mater discovered to be ruptured, but in many, if not all cases, the brain itself is seen to have suffered a serious injury." This was a very clear summary of growing skull fractures and the understanding of these entities that we have today. The first operation was performed for growing skull fractures by Sir Charles Ballance in 1907. Enlarging skull fractures are extremely uncommon and account for less than 1% of skull fractures in large pediatric series. For practical purposes, they're never seen in adults. Almost all enlarging fractures are found in children less than 3 years of age. 2/3 of these occur in children less than 1 year old. The parietal region appears to be the most commonly affected, and most of these cases are seen after severe trauma. Essentially, all writers have recognized that a dural laceration is necessary for the development of an enlarging defect. There has been disagreement, however, about the relative importance of leptomeningeal and parenchymal injury, the microscopic anatomy of the site, and the motive forces that causes fracture expansion. Classification systems for children with growing fractures have been proposed, but have had little clinical impact. Clinical presentation is mostly limited to palpable swelling over the fracture, which may or may not be pulsatile, pain at the fracture site, epilepsy, and progressive neurological deficit may occur if the fracture site is not treated in a timely fashion. Radiographic findings. On plain radiographs, the most important finding is of a diastatic fracture with the fracture edges being at least 3.5 millimeters or 4 millimeters apart. 3D CT scans are noted to have a higher yield in identifying diastatic fractures, and if available, should be obtained in addition to 2D CT scans. In a recent series by Singh et al., The utility of MRI in identifying a high-risk subset of children with linear diastatic fractures was noted. Children who showed signs of dural laceration and cortical tissue herniation on MRI underwent surgery within 1 month of the trauma. Those who did not have these two findings were followed clinically and did not develop growing skull fractures. Algorithmic approach to growing skull fractures should be based on identifying patients who meet criteria for development of growing skull fractures. So children with linear fractures and a severe injury who are less than 3 years of age may or may not have a subgaleal fluid collection or cephalhematoma on presentation, have a neurological deficit, X-rays showing greater than 3.5 millimeters of diastasis, and underlying brain contusion or dural laceration seen on the MRI scan are at a risk of developing growing skull fractures. Amongst these, high-risk findings would include diastatic fracture along with the neurological deficit and, more importantly, underlying brain contusion or dural laceration. If these high-risk findings are noted, early operative intervention should be considered to minimize neurological injury from impending or prolonged herniation of brain tissue. If no high-risk findings, then follow-up in clinic in 4 to 8 weeks with plain X-rays is recommended. And after this follow-up period, repeat follow-up in a few months to ensure delayed formation of growing skull fractures does not occur. At this point in time, almost all growing fractures can be recognized on physical examination, and X-rays are often not required. In affected patients, as we discussed earlier, there is a palpable ossification defect larger than that initially present, usually but not always overlaid by a soft, often pulsatile subgaleal collection. Treatment of a growing skull fracture is operative. Successful repair requires identification of the dural margin, repair of the dural defect, and coverage of the missing bone. A large skin incision is needed. It must extend beyond the margins of the skull defect. The skin flap is reflected in the subgaleal plane, and the bony defect is identified. The dural edge has a tendency to recede and is often located well back from the bone edge. It can be found with progressive removal of bone from the margins of the defect until the dura is circumferentially exposed. Alternatively, a bore hole can be placed a few centimeters from the bone edge, and then a circumferential craniotomy can be performed, which allows identification of the dura around the entire lesion. Once the dural defect is exposed, the underlying brain is carefully dissected. If a large area of cortex herniates through the dural defect, an attempt should be made to reduce it. However, some writers have advocated resection of the herniated nucleotic tissue, which is best avoided in potentially eloquent areas. Dural defect closure is necessary to prevent recurrence of the growing fracture. Primary closure is never possible, so some graft material must be used. There is theoretical advantage to use of local tissue such as pericranium. However, commercially available dural substitutes are often easier to use and seem to be equally effective. There are several options for bony coverage. Most frequently used are split-thickness calvarial grafts, full-thickness calvarial grafts, synthetic material, and split rib graft. All of these techniques have inherent advantages and disadvantages, and each is appropriate for patients according to their age and the size of the defect. It does appear that if the dural closure is good, total bone coverage is less important. In this setting, the defect eventually will fill up with time because of the osteogenic potential of the underlying dura. In summary, growing skull fractures are rare and almost always occur in children younger than 3 years. The inciting injury is often relatively severe, and associated neurological disability is common. Skull radiographs obtained soon after injury demonstrate fracture diastasis more than 3.5 millimeter, and CT or MRI often shows injury to the underlying brain, along with brain contusion and dural laceration. Clinical presentation often reveals pulsatile subgaleal collection. If untreated, the ossification defect often widens over the ensuing weeks and months. Once the diagnosis is clear, operative intervention is indicated. A large craniotomy is often required because the dura can retract several centimeters from the bone edge. Identification and repair of the dural defect is required if recurrence is to be avoided. If unrepaired, growing fractures can continue to enlarge and secondary brain injury and dysfunction can occur. Thank you.